Clinical Pearls in Headache Management, From Theory to Practice. Welcome everyone, and thank you for joining today's session on practical approaches to headache management. In the next hour, we'll explore essential clinical pearls that can transform your approach to treating one of medicine's most common yet challenging presentations. This lecture will be presented by chiropractic neurologist, Dr. George Cook-Rinn. Every day, somewhere between 15 to 20% of the world's population experiences a headache. As clinicians, we often find ourselves at the front line of headache management, tasked with differentiating between the benign and the dangerous, the simple and the complex. Yet despite headache being such a common complaint, its optimal management often eludes both novice and experienced practitioners alike. This lecture isn't about reciting textbook classifications or reviewing basic pathophysiology. Instead, we'll focus on practical, evidence-based approaches that you can implement in your practice tomorrow. We'll explore the art of the focused headache history, learning to pick up subtle clues that can dramatically change your management approach. You'll discover how asking "what do you do when you get a headache?" can often be more revealing than "where does it hurt?" We'll delve into the often overlooked psychosocial dimensions of chronic headache management, examining how addressing a patient's headache-related anxiety can be as important as prescribing the right medication. You'll learn clever clinical shortcuts that can help you rapidly distinguish between primary and secondary headaches, and we'll discuss red flags that should immediately grab your attention in any headache presentation. Most importantly, we'll cover practical treatment strategies that go beyond the standard medication algorithms. You'll learn about simple lifestyle modifications that can yield surprising results, and we'll explore how to personalize treatment plans based on individual patient characteristics and preferences. By the end of this hour, you'll have gained a toolkit of practical approaches that will help you navigate the complexities of headache management with greater confidence and effectiveness. You'll learn when to worry, when to reassure, and most importantly, how to help your patients achieve better control over their headache symptoms. So, let's begin by exploring what I consider the most crucial skill in headache management, the art of asking the right questions.
In this lecture, we're diving into the fascinating world of the headache circuit, a key player in the various types of common headaches we encounter. We'll explore the trigeminal nucleus and its connections with the cervical spine, highlighting the trigeminal-cervical pathway. This pathway has reflex implications that can provide valuable insights for treating most headaches we see in our practices. We'll also touch on neurochemistry and various treatment options, including neuromodulation through cranial nerve stimulation and the use of calcitonin gene-related peptide antagonists. These are crucial components of the neurochemistry behind headaches. Additionally, we'll discuss spinal correction, which has been shown to reduce both the frequency and intensity of headaches. But that's not all. We'll delve into the spinal ganglion and explore a non-invasive method. We're stimulating it along with an innovative technique known as ear insufflation. By mastering these approaches and incorporating one or more into your treatment plans for headache patients, you can expect to see excellent results. Let's get started. In this slide, we have the chemical structure of calcitonin gene-related peptide on the left, an essential player in headache physiopathology. On the right, you'll find the TRPA1 ion channels, which are closely linked to pain processing and interact with calcitonin gene-related peptide. Later in the lecture, we'll dive into the neurochemistry of headaches and explore ways to modulate the release of these two pain-related chemicals.
You may not realize it, but virtually all headache types are caused by dysfunction in the trigeminal system, also known as the headache circuit. So if your headaches are migraines, tension headaches, sinus headaches, virtually all head pain runs through this trigeminal system, and thus the trigeminal system is a valuable target with which to try and treat headache disorders. So let's take a closer look at the headache circuit. It consists of the trigeminal nucleus, which is found in the brainstem, seen here in yellow. And there are several nerves, one of which is the occipital nerve at the base of the skull, the supraorbital nerve, which exits above the eye, the infraorbital nerve, which exits below the eye, and the mental nerve, which is in the chin. All of these nerves are peripheral points of access that allow us to modulate the trigeminal ganglion, which is deep inside the brainstem.
If you've been practicing chiropractic or any form of manual therapy for a while, you probably know that neck procedures often help relieve head pain. But why is that? Head pain is usually linked to the trigeminal nerve, which is cranial nerve number 5, while the neck muscles and structures are controlled by a different set of nerves, C1 through C7. There's a reflex we need to talk about, one that was described years ago. When you stimulate the supraorbital or infraorbital nerve located above or below the eye, as shown in the slide, it can trigger a muscle contraction or a myogenic potential in the neck muscles. This response can be measured similarly to an EMG. What does this mean? It indicates a functional connection between the trigeminal nerve, part of the cranial nerve system, and the cervical nerves, which belong to the neck and somatic nerve groupings. Let's dive into a few studies that reinforce this idea. Cranial nerve 5 and the cervical nerves are indeed functionally connected, and this connection can be leveraged to alleviate abnormal activity in the trigeminal network. This comprehensive migraine study, published in 2003, revealed that most patients showed bilateral trigeminal reflex abnormalities during attacks. A key find was that patients with normal reflexes between attacks responded better to triptan therapy, suggesting this test might help predict treatment effectiveness. This groundbreaking study by Nardone and colleagues examined the trigeminal-cervical reflex in different types of headache disorders. They found distinct patterns of reflex abnormalities: bilateral in migraine patients and unilateral in cluster headache patients. Importantly, migraine patients showed persistent abnormalities even between attacks, suggesting ongoing dysfunction in the brainstem reflex pathways. This study demonstrated a clear distinction between chronic and episodic tension-type headache. The vast majority of chronic tension-type headache patients showed reflex abnormalities, while these were rare in episodic cases, suggesting fundamental differences in their underlying mechanisms. In this study focusing on trigeminal neuralgia, researchers discovered varying patterns of reflex abnormalities. Patients showed either unilateral maladies, bilateral abnormalities, or normal responses. Interestingly, those with unilateral abnormalities or normal reflexes responded better to treatment, suggesting potential prognostic value of this reflex test. Now let's look at a few studies that translate these reflex findings into findings associated with the structures of the neck.